Hello, everyone. Welcome back to another episode of PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Maya.
And I'm Manal. Today we're venturing into the brain to talk about the pharmacology of mood, specifically how we treat clinical depression and bipolar disorder.
It's a topic that touches almost everyone, but the science behind the medications can feel like a maze of acronyms like SSRIs, SNRIs, and TCA, and I don't know what more.
Don't worry, we're going to clarify all of that. We'll look at how these drugs actually change brain chemistry and why some of them require a very strict diet. Ready to dive into the deep end, Maya?
Let's go! So, Manal, before we discuss the medications, it's important to clarify what we're treating. Feeling down from time to time is normal, but clinical depression is a more persistent and serious condition.
It's not just a slang term for being sad. It involves emotional symptoms like persistent misery, apathy, and feeling worthless. But there's also a biological side to it, things like loss of appetite and even slowed down thoughts and movement.
The leading theory is monoamine hypothesis. Basically, the brain is running low on monoamines, specifically norepinephrine and serotonin.
So think of these drugs as a way to refill the tank or stop the leaks so that the levels stay high enough for the brain to function normally.
Let's start with the old school class, the TCAs. Think of the drugs like amitriptyline or imipramine.
These are pretty potent. They block the uptake of both norepinephrine and serotonin, effectively keeping them in the synapse longer.
But they have a reputation for being dirty drugs. What does that mean exactly?
It means that they aren't very picky. While they hit our main target, they also block the muscarinic, histamine, and alpha 1 receptors.
Wait! That basically means you get the full package deal of side effects. Dry mouth and constipation from the muscarinic block, extreme sleepiness from the histamine block, and that dizzy head spin when you stand up because of the alpha 1 block.
Yes, and listeners, please remember the 3 Cs of TCA overdose: Coma, Convulsions, and Cardiotoxicity. They can be very dangerous for the heart, which is why we monitor them so closely.
Phew. Thankfully, the SSRIs came along. Selective serotonin reuptake inhibitors. Drugs like citrulline.
Yep, these were game changers because they are selective. They leave those dirty receptors alone and focus almost entirely on serotonin.
So they're much safer, but they do have their own quirks, right?
Well, yes, you are right. Many patients struggle with sexual dysfunction or GI issues, and if you stop them too fast, you get discontinuation syndrome. It feels like a bad flu combined with extreme irritability. It feels like the brain throwing a tantrum because its serotonin supply was suddenly cut off.
And don't forget the SNRIs, like venlafaxine.
They're like the middle ground. They hit both norepinephrine and serotonin, but without the scary heart risks of the older TCAs.
Quick question for the listeners. If a patient complains of a racing heart and seizures after taking too many of their old-style antidepressant pills, which class are we worried about?
That's the TCAs. Those are the classic signs of the 3 Cs we mentioned earlier.
Now we have to talk about the monoamine oxidase inhibitors, like phenylazine. These take a totally different approach.
Instead of blocking reuptake, they block the MAO enzyme, which is the shredder that breaks down the neurotransmitters.
But this leads to one of the most famous warnings in medicine, the cheese effect.
It sounds like a food blog, but it's actually a medical emergency. Foods like aged cheese, red wine, and yeast are high in tyramine. Usually, MAO breaks tyramine down, but if that enzyme is blocked, tyramine floods the system and causes a massive hypertensive crisis.
So if you're on monoamine oxidase inhibitors, your charcuterie board is officially off limits. Finally, let's talk about bipolar disorder. This is the swing between the lows of depression and the highs of mania.
For this, we use lithium. It's the gold standard mood stabilizer, even though scientists are still debating exactly how it works.
Did you know that 7-Up actually contained lithium citrate until the late 1940s? It was marketed as a mood booster.
I can't imagine seeing that in the grocery store today, especially because lithium has such a narrow therapeutic index. The window between its working and its toxic is very tiny. If the levels get too high, they cause coarse tremors, confusion, and kidney damage. You have to get regular blood tests to make sure you're in the safe zone.
Let's do a quick recap before we head out.
Depression is often a deficiency in norepinephrine and serotonin. TCAs are effective, but dirty. Watch out for the 3 Cs: coma, convulsion, and cardiotoxicity.
And SSRIs are the modern selective choice, right?
Yep. Watch out for sexual dysfunction and taper slowly. And Monoamine oxidase inhibitors are the enzyme blockers.
No aged cheese or wine unless you want a hypertensive crisis.
Yes. And lithium is a bipolar stabilizer. It has a narrow window, so watch those blood levels.
And that is our journey through the world of antidepressants and mood stabilizers.
I hope that helps clear the brain fog about these medications. Thank you for having me, Maya.
Of course, thank you for listening to PodBites.
Stay curious and stay healthy. Histamine and alpha-1 receptors. Don't say that. No, Maya. Maya, don't say that.
Hello, everyone. Welcome back to another episode of PodBites, where we take down complex medical topics and break them.
Break down.
What?
Where we take down.
No, when we take.
You said take down.
Whatever.
Block the uptake. عمو ايش فيك انت؟